Hello and welcome to the Dizziness and Balance video series by the Ear and Balance Institute. I am your host, Dr. Jared Gianoli, and I am a board-certified neuro-otologist. Neuro-otology is the medical specialty that deals with inner ear dizziness and balance disorders. This video series is intended to be educational and not intended to be medical advice. For individual medical advice, please speak with your own physician. In this video, we will be discussing benign paroxysmal positional vertigo, BPPV, and this is the second part on BPPV. If you haven't yet seen part 1 of BPPV, I'd suggest you go look at that video first. In this video, we're going to talk about the typical versus the atypical types of BPPV, and we're also going to talk about treatment. As we reviewed in the first part, BPPV is caused by loose crystals, calcium carbonate crystals, that have broken loose from the utricle, which is one of the gravity sensors from the inner ear, and these crystals have floated around and gone into the semicircular canals. The most common is for the crystals to get into the posterior semicircular canal. Now, there's two broad categories for BPPV. There's canalithiasis and cupulolithiasis. Canalithiasis is when those crystals are free-floating in the canal, and that's by far and away the most common type of BPPV. So when these crystals are free-floating in the canal, if there's just a few of them, it really doesn't cause any symptoms. But if they get a big enough clump of them together, they'll plug up one of the semicircular canals such that when you change your head position, they will float down and act like a little plunger, pulling the sensor and giving a brief episode of vertigo. The other type, the cupulolithiasis, is when those crystals get stuck to one of the sensors of the semicircular canals. In that case, it acts like a weight on the sensor, and such that anytime your position is changed just a little bit, you'll get abnormal stimulation. It's not near as common, but it generally causes much more significant symptoms than canalithiasis. So among the scenarios we see with BPPV, the most common is posterior canal canalithiasis. Now, that's one of the vertical canals oriented up and down, and it's located in the very bottom of the inner ear. And they generally feel that these crystals will go sink back there when we're sleeping at night. And these will generally be affected by rotation in bed. Rolling over to that side is the most common way these crystals will clump and cause stimulation of vertigo. That probably represents about 85 to 90% of BPPV cases that are seen by clinicians. Second to that is involvement of the horizontal semicircular canal. Now, those are the semicircular canals that are located in the horizontal plane. In this case, it's much more common to see cupulolithiasis than you will see canalithiasis. And I think it's simply because the anatomy. In the horizontal canal, they're not just in the horizontal plane, they're tilted up a little bit, such that the crystals will generally tend to kind of fall out of the horizontal canals unless they're stuck on the sensor. And that's why I think we see cupulolithiasis more commonly in horizontal canal. Much more symptomatic for these cases. And what we see with horizontal canal cupulolithiasis, or for that matter canalithiasis, you'll get symptoms whether you roll to the right side or the left side. So it'll seem like you've got it in both ears, but it's really just in one ear. Further, horizontal canal involvement, those patients will note problems when they're turning their head side to side, much more so than you will see with posterior canal BPPV. The last is the upper balance canal. We call that the anterior canal. We also call it the superior semicircular canal, but it's the one that's located at the very top of the entire inner ear, and it's the one obviously least involved just because of we usually don't hang upside down. But when the crystals get into that canal, they fall all the way down, and they're almost always a case of cupulolithiasis because the crystals will naturally, from gravity, fall onto that sensor. Now, the interesting thing with anterior canal BPPV is those patients usually have mild chronic symptoms present all the time. They feel dizzy and off balance almost any way their head is, except for when that canal is in a non-dependent position. Last, I would say there's multiple canals. You can see BPPV present in 1, 2, 3 canals all at once. And in those cases, you really have to step back and wonder, why are there so many crystals all over the place? Which brings me back to our next topic, treatment. So back when we first started learning about BPPV, we weren't as cognizant of the fact of why do these crystals break loose from the utricle to begin with. Well, it turns out there's a variety of different reasons. And so for somebody who has recurrent or chronic BPPV, the first thing the clinician should ask themselves is why? Why is the utricle being damaged? And the first step is controlling that problem. If you control that problem, very often the BPPV will go away on its own just by normal head movements throughout the day. If that doesn't suffice, then there are maneuvers that can be done. The first and most popular procedure, we call these canalith repositioning maneuvers, but the first and most popular is the Epley maneuver. A gentleman by the name of John Epley, who was a physician in Oregon, developed a procedure where you can basically float those crystals out of the posterior semicircular canal back toward where the utricle was. And this maneuver became known as the Epley maneuver. It is very successful in treating posterior canal canalithiasis. Now, it doesn't treat any of these other types or these atypical types. And for those, there's a variety of other maneuvers that you can do. The maneuver that Dr. Epley put together for us, he recognized from the beginning that this was only treatment for the posterior canal, and it was really kind of a workaround. I mean, the ideal way of treating this would be just go completely 360 degrees across the axis of that canal. So he developed a chair called the Epley Omniax, and this chair is basically you strap the patient into this chair, 6-point restraints, and you can turn their body 360 degrees in every direction while monitoring their eye movements so you can get an idea where the crystals are located, and you can rotate the patient around to dump them out of the canal. It's a marvelous machine, and I was fortunate enough to be one of the physicians that helped Dr. Epley get FDA approval for the device. And I've had one of those devices in my office since 2007. And it's great because it makes finding and identifying where the crystals are located and getting them out much easier. It's a mouse click for the most part. And this was I think a huge advance in the diagnosis and treatment of balance and dizziness disorders. Unfortunately, the company went bankrupt because of insurance reasons, and there's just not that many of those left. If you have someone who has a recurrent BPPV, there are other things you can do. There's these things called Brandt-Daroff exercises, where basically the patient can sort of do a mini Epley maneuver every morning to try and get those crystals out. It's something that I rarely recommend to patients, but if you have someone who's got recurrent BPPV and there's no other available options, this appears to be a reasonable way to approach these folks. Lastly, there's surgery. So back when we first identified what was causing BPPV, and I'm talking about back into the 90s, the Epley maneuver was not as utilized back then, and the recognition that there was these other problems causing the BPPV was not so well known, such that there were lots of patients with recurrent BPPV. And so consequently, I did a fair amount of surgery on these folks. And what we would do is basically do a mastoidectomy like we do for little kids with mastoid infections. And then we'd open up the posterior semicircular canal and plug it up with fascia or muscle or something like that, and then seal up the canal. And in essence, what it does is it locks that sensor in place such that it doesn't matter where the crystals are. It's not going to make that sensor move. It's a very, very highly effective procedure for eliminating BPPV. It was, again, something that I did a lot of earlier in my career, but the further along I've gotten in my career, the less I've needed to do this, such that I've probably only done 2 in the last 5 years. And when you consider how many cases of BPPV that I see, and I see the worst of the worst, that says a lot that that's such a rare procedure for us to do. In any event, that is a kind of a last case scenario. It's very effective, but keep in mind it's mainly just for the posterior canal variant. So that's the runabout for treatment of BPPV. You also have to keep in mind that in addition to BPPV, these patients almost always have something else going on, and there should be treatment directed toward what the other problem is. And that's something we'll explore in other videos. Thank you.